Can you hear me back there? Okay. So the system is not working. The front door of this thing is open. There's a huge cable going onto a new projector because Barbara Casper broke the projector last night. And you would think there is a crisis. There's pandemonium, just heard the term. We're going to talk about that today. Now, as is customary, the chair of the Department of Medicine starts the first grand round of the year, and I'm going to do so. And I'm pleased to do so and present a little bit of information about the department and where we are, our place in time. But it's also customary for me to introduce a little bit of history, a little bit of someone or some event that changed the way we think or we deliver healthcare or we think about medicine or biology. And there was a lot to choose from today on September 3 in history. But I chose this event, and you'll see why in a minute. This day, September 3, did not happen in Britain, in Ireland, or the English colonies in 1752. It did not happen. And there were riots on the street. Riots, I tell you. Why? Because the calendar had gone out of sync. The Julius calendar, which we have used because of Julius Caesar, had gone out of sync with the solar calendar, with the solar cycle, and the equinox, and all these things. And those of you who are astronomers would understand what I'm saying. So it had to be fixed. And the way to fix it was to get rid of 11 days. We had done this before in the 1500s when we moved into the Julius calendar. And now we're using the Pope Gregory 13th calendar. And this is his picture. But people did not get it. People did not understand it. The government stole 11 days out of my life, out of my children's life, out of my pocket, out of my opportunity. And there was chaos. Chaos. And just like today with the little bulb and the little phone thing that now they're going to steal my identity, I'm sure you're thinking about it. There is no chaos. There is no crisis. There is a cycle. And if you understand your place in time and you understand your place in that cycle, you're better able to define where you're heading, when to invest, when to not. Now, the mark of a mature, psychologically healthy mind is indeed the ability to live with uncertainty and ambiguity, but only as much as there really is. Uncertainty is no virtue when the facts are clear. Uncertainty is no virtue when the facts are clear. And ambiguity is mere obfuscation when more precise terms are applicable. I'm from Puerto Rico, and the term obfuscation, I like it. So another tradition of these grand rounds is that we start with a case. And so I'm going to start with a case of obfuscation. And this was brought to me since July, because you may or may not know that I meet with all the students. I meet with third-year students for 1 hour over pizza and Coke, and we talk about career choices. And then I meet with every student that is going into internal medicine, and I meet for them for about 30 to 40 minutes, and we talk about where they're heading. And I ask them one question: where are you going to be 25 years down the road? And we discuss interview strategies. That's the most important for me at that stage. It's just they're our students. I want them to do well. We talk about how do you have a lot of strength. How do we work that out to make sure that you look well? Okay? And so I know that this may be a shock to you, but this is what I see in 90% of the people that I interview. This is the case of a 26-year-old medical student searching for answers. Her physical exam and vitals were normal, but her history was very telling. Parents had warned her about uncertainties in healthcare. In fact, her father is a physician and had even mentioned, perhaps you don't want to go into medicine. Things are not the way they were, honey, when I became a doctor. The attending warned her about a career in research. The days of the triple threat are gone. Dollars at the NIH are down. you may not be able to make that. The sibling has gone into business because doctors are making less money. It's chaos, I tell you. Huh? There's uncertainty about the future of academic medicine, and therefore she's contemplating a job in private practice, which is fine. And when I talk to them during the interview, I tell them it is okay. We have a great system because we have people in academic centers and because we have great doctors in private practice, and we want to generate people in both places. Equally important. But make a decision based on clear data. Because uncertainty in the absence of data and precise terms to define it is obfuscation. Okay? And what bothered me the most is that nobody in this medical school addressed these appropriately. Nobody. Now, I may be wrong about that. Because in the ICU, I see cancer patients all the time. And when I walked through the door to explain to the family that the pneumonia and the septic shock had been related to the cancer, all of a sudden there's shock. Cancer? Nobody has ever told me that. Even though the record is full of discussions for 2 years of cancer. Because we hear what we want to hear. We see what we want to see. We interpret what we want to interpret. And our students remain uncertain, perhaps despite our best efforts. I get it. But we still have to change that. We still have to change that. So today, I'm going to give you some facts. And you will determine what you tell your students in your interview. So why are students and faculty uncertain? And I include faculty because if my students are uncertain, it must be because my faculty is uncertain. Give me another explanation. Let's figure out. Well, we live in uncertain political times. I don't need to tell you that. Just turn on NPR. We live in uncertain economical times. And we live in uncertain local times. So when there is such uncertainty, there is uncertainty among us. And we reflect that. Believe it or not, students get it. Whether you say it or not, they sense it. So I want you to stick to your circle of influence because you cannot demand, certainly you can try, but you're not going to change whether the Iran plan is signed off or not. And you're not going to change the economy of the world. And you're not going to kill ISIS tomorrow. And you're not going to prevent somebody to take in a job somewhere if you can. Okay? So stick to your circle of influence as Harvey told us, Stephen Harvey, and the 7 Habits of Highly Effective People. Outside of your circle of influence, there's concern. Why concern yourself with it if you can't do anything about it? Concern yourself with the things you can influence. That brings certainty, definition, clarity. So what are the things that we can influence? Well, we can influence, I'm not telling you anything new. Can I be a good practitioner? Can I take great care of patients? Can I engage in meaningful research? Can I educate and mentor others? Can I be mentored appropriately? Can I get promoted? Am I fairly paid? Those are the things that you can influence. The rest is out there. Here, there is certainty. Now, the other thing I want to tell you is that I think we lose track of the place and time where we are because we don't realize that everything is in cycles. Everything is in cycles. And if you don't know in which part of the cycle you are, you sense things in a different way. In fact, perhaps because you don't know in what part of the cycle you are, you feel uncertain. Think about it. If you're here, you're making decisions differently than when you're down here or up here. No? And that has an impact on, can we explain our circumstances? Can we predict where we are headed? Can we define how to invest and where and when? And can we make improvements and gains and reduce our losses? This is true for academic medicine as well. Do we know our place in that? So as tradition, I've mentioned the 4th tradition of the day, we go back to biology to understand a little bit about this. One of the things biologists tell us is everything is about cycles. Here's a cycle of the cycling genes during cell proliferation, their ups and downs. The cardiologists tell me about the cardiac cycle, and the endocrinologists tell me about the cortisol melatonin cycle, and day and night. Cardiac cycle here for the cardiologist. Kareem tells me about the sleep cycle. Sometimes we're down, sometimes we're up. But if we wait just a few minutes, just a few weeks, just a few years, we will be upside down again. And it's a matter of being patient and continuing on the right path towards a long-term vision that we know we have. Metropolitan regions have a cycle. Did you know this? This is the Berg cycle described in 1982 by Dr. Berg, where there's cities, the economic impact, and everything is happening downtown. And then people moved into the suburbs. And the cities lose the traction, and they become a little bit sort of disheveled. And then over time, that gets recovered. And we see some metropolitan areas in the United States now recovering that again. And it's that cycle. And this is a cycle of decades, and it's different. And there's still some uncertainty about the future. But it's in cycles. Industry has cycles. Yes, Kentucky has cycles. This is thoroughbred sales and business investment. And if you're here, you might want to invest in a big, nice, fast-running horse. Pharaoh. If you're here, you might want to invest in a bicycle. But are you right in making that decision? Are you right if you don't know where you are in that cycle? The GDP cycles. This is an interesting slide. This is disposable income, U.S. per capita disposable income in gold. Think about it. If you're thinking that you need a new car or a new house or your kid is about to go to college, you're probably going to make a very business decision that if you're here, on if you're here. And in fact, if you make the decision when you're here, you're going to get the fast car, you're going to get the biggest house, and you're going to get your kid into the most expensive university, not knowing that just a few years later you will be down. And vice versa. And the people in the stock market do this all the time, not knowing what the future will be, but they have signs, and they know the crises, and they know the world, and there's uncertainty. And whenever China's dollar go down, ours goes down. It's weird. And we worry about all that. But it's not within our circle of influence. Chair cycle. If you look at our history, there's 172 chairs, and from John Cook to Dr. Richard Redinger and myself, there were 172 years, about 8 chairs per year. Some more, some less. There's cycles. Oh my God, there's a new chair. What will happen? I will be fired. Oh my God, we've had the same chair for 6 years. So boring. It's in cycles. You just wait for the next because you know where you're headed. So, do we know where we are in this cycle? Do we understand where the topics of influence are? Do we understand that we're not in chaos or crisis? And what are we telling our trainees about it so that they understand their circumstances, that they can predict where they're headed, they can define their investment? And when I ask them, where are you going to be 25 years from now? They tell me. They tell me. I'm not asking for them to know the future. They're students, for God's sake. They're going to change their mind in the next 3 or 4 years. But at least today, if something were to happen, they know where they're headed. And if you don't know where they're headed, you don't know what residence to choose. And if you don't know what residence to choose, you don't know where you're going to be. And if you don't know if you're going to think about private practice or academia, you have missed on the most important decision you're going to make in your life. Are there students here? Have you heard this before? So you may say, well, wait a minute, I can't do all this, Jesse, because I would have to keep track of everything, even population shifts. No. Well, but Jesse, look at this. My career is cycling. My personal life and economy are cycling. There's misaligned. Some of them are, it's all over the place. And I go back. Stick to your circle of influence. Can I be a better doctor? Can I take a better care of my patients? Can I educate to my best of my ability? Am I well paid? Can I get promoted? Can I mentor the person next to me? That's what we worry about. Because there is certainty here. So let's talk about the numbers. Let's talk about what we can influence so that when you leave here, you decide what certainty is there. Okay? So people tell me they can't do research anymore. This is the worst times to do research. Craig McLean tells me he's worried about this. He didn't tell me that. He's not worried. Okay? But think about this. This is weird. Journals. I just chose some data. I could give you publications. I can give you discoveries. Journals are getting out of control. You see this all the time. But we have more science than we can handle. We can't even interpret all the science that is coming out every day. The NIH has been investing in research forever. This is since the 1970s until now. Yeah, it's plateauing out a little bit, but compare that over the past decades. There's a lot of money being invested. Look at this. This includes trends in R&D by agency. It includes NASA, the Department of Defense, Environment, NSF, NIH, all of them, and there's cycles. There's cycles. Down, up, down, but it's going up. We're in a high time of investment. So research is going up. A lot more people are engaged in this. There's a lot of money invested. How do you explain this? This is the number of young people, 36 years old or younger, who have NIH R01 funding. It's been going down since the 1980s, whereas the old people are taking over. Today, there are more old people, senior people, experienced people, let's call it that way, with white hair, who are funded. And our junior people, who are going to take over us when we go, are not around. Explain to me why that is. Because all the data says that this is the time to invest. Are we giving our students and our trainees the wrong information? Why are we uncertain? Just giving you data. Where we are in research, $33 million in research. We have sustained in the top 50 of NIH ranking despite concerns and problems. Chaos, I tell you. This will not look good on the video. Can you still hear me? I'll soften my voice. 300, 400 publications per year. Clinical trials enterprise doing well. They have a beautiful active clinical trials unit at ACOC. We have about $40 million in potential if we were to recruit every patient we have on clinical trials. We have world-class basic and clinical trials in basic science. World-class. I'm not kidding you. It's not that I'm just because I'm proud of what you do. It's true. It is reality. And I visit a lot of places every year. Okay? Where is the uncertainty about science in this place? Where does that come from? Let's talk about education. If you want to be a doctor, think about it, medical education, you will want to be in a country, in a place that has a lot of people, because people get sick. The population of the United States keeps on growing. The projected centenarians in 2050 will be close to 1 million people. You think they will need a doctor? People living with HIV, people living with obesity, incidence of diabetes, cancer deaths. Some of these are the 1930s, 1960s, 1980s. This is moving up in many areas. There's more people, more octogenarians, more disease prevalence. Do you think we need doctors? There's more educated people. This is the number of people with bachelor degrees in this country. There are more college people that could envision a career in medical education. And yet we see this. That since the 1970s, maybe it's 1980s, we plateaued. So we see more population, more patients, more disease. There's a need for more doctors, and yet we're not educating more people. Why is that? The data doesn't suggest that that's what would happen. Is that what we're telling our children? Don't go into medical education. It's not what it was when I became a doctor. Well, there's more need for you. I don't care if it was the same. Think about it. Now, here's where we are. We have 100 residents, internal medicine, med-peds, prelims, over 60 fellows. I never have the total count. Over 10 specialties, all of them well accredited. Trainees being recruited in top places. School of Medicine responses, LCME needs. You saw the dean recently showed an announcement that we're probably going to be on track again very soon. Our board pass rate is 91%, higher than the national average. We have 92% match rate. People going to Vanderbilt, Hopkins, top programs all over the place. Why aren't there more doctors? Why aren't there more people seeking medical education? Is this because we are giving them misinformation? Is this because we have lost our place in time? Is this because we don't understand the reality of cycles? Because the data is clear to me. I want to put a plug for Louisville Lectures. Where's Mike? There he is, back there. These people have worked very hard to create this internet-based foam ed. I'm learning a lot about it. But you guys, many of you have already developed lectures for this that are on the internet. In fact, a couple of chairs have brought up to me recently the need to have some people come give them lecture. And I said, why don't you try this first? And they love it. YouTube page has over 3,500 subscribers and over 85,000 views. Subscriptions are growing 10 to 15% per month, 12 to 15% per month. Over 60 published lectures. Podcast has quickly grown to about 50% and over 45,000 total views since March. Website has over 7,500 unique visitors. They have been syndicated, so to speak. This is a big deal. This is the first department to get into the foam ed space. Am I correct? Yes, sir. Okay? So we're moving in education here and outside in ways that we could have not predicted. But now people in Pakistan and Russia and next door have access to our great educators. What are we missing then? Where is the uncertainty? Let's talk about patient care. So we have programs of excellence. I've told you this before. You've seen my letters. But I want to mention them. Bone and joint infection, congestive heart failure, interstitial lung disease, pulmonary hypertension, cystic fibrosis, lupus nephritis, GI motility, interventional pulmonology, sleep, hepatology, obesity, pneumonia, transplantation, cancer. Why am I saying this? So that you are overwhelmed with what you got. Locations, downtown, southern Indiana, and we're now moving into the East End. I can tell you that another time. And Kentucky Will Health provided dollars to recruit more clinicians. $6 million over the next 3 to 4 years for the Department of Medicine alone to increase people. That's why you see more people being recruited. Okay? How about finance? Because we always join patient care with finances sometimes. Well, people are worried about UOP. 3 years ago, what are we doing? We're going to lose money. Dr. Roman got us into this business. And a corporation that now is a $120 million corporation has been born. And we joined the world by being in the 80 to 90% of institutions that have a unified clinical practice plan. And look at where we are. Look at pay per work RVUs is going up. Days on AR is going down. It's not where it needs to be. Not where it needs to be, but it's going up. And for the first time since the inception of this corporation, just 2.5, 3 years ago, we made money this year. UOP did not lose money. It made money this year, in part because multiple departments, including ours, are doing better. And that helps with the bank, because look at our debt cover ratio. If you know banks, you know that your debt cover ratio cannot go below a certain line because your interests go up. And our bank is happy, or not, depending how you see this, if you're the banker, because we're doing well. We're doing well. Look at the Department of Medicine. Here are revenue in millions, 94 in 2013, now projected to be 107 million when that's research, that's everything, patient care, everything, in 2016, projected. Here are our projections based on data for this year. We still have a deficit. You know that I've discussed this with you, but that deficit is not growing. We are chipping it away. And here are our projections. Now, I want to define a couple of things for you. Here are the projections for 2015, where we projected having this revenue and these expenses. We were going to lose over $2 million. It didn't quite work that well. But based on how we have been doing over the past year and this summer and in July, look at what we're projecting for next year. We're going to be right where we need to be. And from there on, we're going to be chipping away even further our deficit. There is no uncertainty here. Research is on the right track. Education is on the right track. Patient care experience is on the right track. None of it is perfect. But is this the message that we are internalizing? And is this the message that we exude when we sit around with each other and with our trainees? Let's talk about faculty development. We have 205 faculty. We had about 135 when I got here. Standardized processes for reappointments, evaluations, promotion. It's been painful. I know it's been painful for you. You think it hasn't been painful for me, but it was the right thing to do, and we're driving the way this institution handles its faculty in a fair way. In a fair way. This is a little bit of information of recruitments per year, and you see a little bit of women and minorities. The minority curve has minorities and women in there. That's why it looks a little bit higher than what it really is, but we're doing well in diversity. Look at some of the awards. This is just a few. I'm missing a few people here. Juan Guardiola. When you see Juan Guardiola, celebrate him. He won the President's Award for Service and Profession. Monica Shaw is sitting back there, one of our own, KMA Education Award. Roberto Bolli wins the Lifetime Achievement Award from the International Society for Heart Research. Don Miller and William C. are recognized as top doctors, cancer doctors in the United States. It's not in Louisville. This is not the Louisville Magazine. But in the Louisville Magazine, we have a lot of people, as you see here. 2 nephrologists. Kudos to nephrology. They always sit on the side, which, as you know, is the left kidney. Aruni Bhagnagar in cardiology is chairing a study section. New positions. Lori is in charge of palliative medicine. Lori Wagner is ACOS for education. Eleanor is the new ACOS for research. Over 35 successful submissions to the honorary Southern Society for Clinical Investigation. Over 27 faculty have been promoted since 2010, and more this year. The paperwork is coming in. Over half of the School of Medicine's distinguished awards have been in this department. There are over 16 departments, but over half of them have been here. There is no uncertainty here. We earn less money. I got a call. I told you this story some years ago. A friend of mine said, my kid is interested in medicine. I'm worried because I'm told that doctors earn less money. My reaction was, independent of the data, if your kid is deciding based on money, send them to business school. We're not here because of money, but we want to be paid fairly. Let's see the data. So yes, we are earning less than some years ago. Medical specialists, 2.1% less. But let's look at the data. If you look from 1987 to 2010, blue is men, women, dentists. So these are physicians, these are dentists. We're still higher than non-healthcare workers. Much higher, I tell you. Where is this coming from? Why is there uncertainty about what we tell our trainees, about what we think when we walk around the hallway? Smile, because there's no uncertainty here. So if we have all of this, then where are we in this cycle? And I put an arrow, okay? I think this is where we are in the cycle. Why? Because I think I have a good sense of the cycle. But recently, we were here, and then we saw the Humana issue. Then we saw the passport issue. And then we got into Kentucky One Health, and that paralyzed us for 2 years because we didn't know where we were heading, and there was a lot of complexity in that process. And then the LCME came, and they didn't like what we were doing at the school. And all of that is changing. UOP is moving forward. The Kentucky One Health issue has been here for 2 years. We understand where that is coming from. The school is going to do well in a couple of months. The department is making money, and I think we're in the upswing. And so I want you to tell this to each other, and I want you to tell this to the students, but mostly when you're in committee meetings, you tell the Department of Medicine is an up here swing, and this year is a time to invest. We want money. We want resources. We want more faculty. We want more students because we take advantage of the cycle. And we're in the upright swing. We're there. We're there. Now, you might say, well, Dr. Roman, you chose the data, what data to provide us? No, you were very decisive of what kind of data. That's a little sneaky of you. Huh? Yeah, because I'm an optimist. And only optimists make it happen. And I want this group to be the same. Because the human spirit is the ability to face the uncertainty of the future with curiosity and optimism. It is the belief that problems can be solved, differences resolved. It is a type of confidence. Confidence. And it is fragile. And it can be blackened by fear and superstition. And I'm telling you, for some reason, our kids are believing in superstition. So, the Department of Medicine houses the largest clinical enterprise. the largest research enterprise, and the largest educational enterprise of U of L, and is doing extremely well, and is now the second, not the third or fourth or fifth, the second largest money-generating enterprise at UOP. You think there's a reason for optimism? So we are in this cycle, and what are we going to do with that investment? All these millions of dollars that we're going to get because we're in this uphill cycle and because we're confident. In this slide, you have seen before. You saw this last year because we're not done yet. In fact, we're not even scratching the top. We're starting. We have to engage more in quality. We have to do more personalized medicine. We have to get the Global Health Initiative to be university-wide and be the best global health initiative in the country. We have the ability to do that. I'm optimistic, but not stupid. Primary care. We need primary care. We got to do that. We got to continue in discovery. And yes, we have to find a way to engage in legislative approach. We tried last year. They hit it in some VA committee. We got to find a way, because I taught you last year that it's only through discovery and legislation and public policy that we will make differences in healthcare, that we will improve how health moves. And despite all these things that I have told you, the health index of Kentucky remains the same for the past few decades. Okay? So we have to do something about that. I can see 100 patients per day, and I will not change the health index of this town. I will not. It has to be done by discovery, and it has to be done by implementation of public health through legislative action. I didn't make this up. I'm optimistic. Okay? So I'm going to leave you with this, and we have plenty of time today, and I did this on purpose so that we have a lot of time to discuss, because in previous grand rounds, we don't have a lot of time to have conversation. Today we'll have conversation. But let me leave you with this. Embrace relational uncertainty. It's called romance. Embrace spiritual uncertainty. It's called mystery. Embrace occupational uncertainty. It's called destiny. Embrace emotional uncertainty. It's called joy. Embrace intellectual uncertainty. It's called revelation. And somebody added something. Embrace academic uncertainty. It's called opportunity. Thank you. Questions? Questions and comments? Do I lie? Tell me. You're the ones who are talking to our students, to our residents, to our faculty. Did I make a mistake here? Am I seeing the signs in the wrong way? Am I still confused about my place in the cycle? You tell me. Is this too much? Mike, tell us more about the lectures you're taping. Louder. Yes. And we're working on accreditation of those lectures for continuing medical education credit. Should have that established in the next few months. Great. Yes, sir. Something about your data as far as expanding research and funds. Left out the concept of consolidation. So you have people that are older having more ROs. You have people who are younger having fewer ROs less. Obviously, policies have to be in place in the United States health framework. We need people involved. But with failure rate being as low as it is for an auto Dr. Dryden is bringing a good point, and that is that great scientists are hogging the money. That we have some older people who are at good place in their careers, but are really should be spreading out dollars. And we have some scientists who have 3 or 4 hour ones. The NIH has been discussing for quite some time the idea of limiting the number of grants that you actually get. I will tell you that there is quite a bit of resistance to that because some people say the funding should be based on productivity. And if you're productive and you're using taxpayer dollars, you want to put that money in where you're most likely for success. Where is Dr. Bowley? Dr. Bowley, tell me about that, this idea of giving more money to some versus others versus productivity. So there is debate on how to best address this and how to best attract more people into research. But I think you're totally right. The funding rates are a little bit lower because there's more people applying and the dollars haven't continued to increase. On the other hand, I think that if there were more people excited about it, I think it would be easier to address the problem. I don't have the answer. There are multiple science minds thinking about this. I don't have the answer for that. But the answer can't be I'm shying away because I think it's not good. I'm shying away because I'm uncertain whether I'm going to make it. I mean, I have people who tell me all the time. Just yesterday, I asked somebody, have you considered a career in academia? No, I don't want to be a researcher. So there's this also misunderstanding that academia equates research, when many of my best faculty are not researchers. So I think there's a lot of misconception, and I think that those realities that you're talking about are heightened by a lot of misconception. But those realities are real, no question about it. Tell me about research, Greg. What's going on? The good stuff. Because we're optimists. Right. Yes. I think I know what to do to combat it, but I don't know the historical facts that led to this. Or does the community have the right thought about who we were? Because I think reputation takes many years to develop. It takes only one day to crush. Okay? So I think the reputation U of L has is a reputation that is based on 34 years of what had happened, not where we are today. Do you guys feel the same way? I don't know that that's true. Yes. Yeah. Yeah. We can't control them, but our circle of influence includes marketing. What are we doing as an organization to show what we are and who we are? And somehow, every institution I've been under invests in marketing. Every institution I've been. It takes millions, hundreds of millions of dollars to do an appropriate marketing enterprise. And with the good things we have here, a marketing strategy would double the stuff that we do. Easily. But it takes guts for someone to say, here's where I'm going to put the money. and the resources, because you have to balance. Do I do that, or do I keep the HIV clinic open? No, and so it's not that people don't want to invest. It's just there are priorities. But at some point, we're going to have to make the decision that reputation is important and that we have what it takes to back that up. Okay? Yes? Influence. No, good point. By the way, your voice is not better. Come to see me tomorrow. You raised a very important point, and that is that there are two issues here. One is we're burnt out and we feel stressed out and so forth. And the other issue, what are the systems issues that actually perpetuate this? So there's two aspects here. How do we get the ULP clinic better? How do we get our clinical enterprise at 310 better? It's chaotic over there. No, we got to get that better. But at the same time, how do we improve the mental health of our physicians and our nurses and our students about feeling well about themselves and how to address stress and so forth so that one doesn't impact the other, but they both work together. And I think perhaps we need to develop a group to begin to tackle those two issues separately. That's a very good point. What else? Okay, good point. Neil brought up the question of reorganization. We are considering strongly do a lot of changes. The changes in space are done because we want a better space for AIM. We want to improve capacity at HCOC. We want to have more space for BMT to expand their clinics. We want to have more space to have Global Health expand their enterprise. We want to have a number of things. So we're now discussing very strongly reorganization of all these clinics. With respect to AIM, we're moving into different, better space. People are the same. Providers, physicians are the same. Trainees are the same. Staff will be the same. But what the difference is, you'll have the specialists and everybody else in the same area. So we're consolidating our clinical enterprise, our general internal medicine clinical enterprise to the same space. But faculty, staff, and everything else has not changed. It's just from one location to another. Nothing else changes. Nothing else changes. Believe me, Neil, okay? No uncertainty there. We're doing this to make things better and patients to get better care, not to prevent them. In the past, I think there's been this issue that there's this unwritten role that we don't see indigent patients at HCOC. Is that where you're coming at? Yeah, and you're bringing up what she brought up. The issue of, are we doing the systems issues that we need to do to ensure that whatever change we make, it's accompanied by what we need to do to keep it efficient. And what I'm saying is, if you have the same people, the same call people, the same nurses, the same NPs, the same doctors, you're just moving to another space, nothing is changing. Now, that's bad too. We want it to be better, but it shouldn't be worse because we're having the same call people and same things, okay? But you bring up the concept of UOP clinic. HOC is not as efficient as it should be. We agree. And in fact, UOP is trying to develop a large call center for the entire enterprise to start to address that. That's why we haven't tried it ourselves, although we have sort of a mini call center, but it's not working as well as it should be. Yes, you still have time. You still have me up front. Jen, tell me about education. And I know about that because I see more and more interviewing with me. Good, good. Questions, comments, good things. Yes, sir. Look, notice how the finger just went up. Not the hand, not I'm standing up. It must be that we're going to talk about IT. Two of the top things that students have told us not to come here is we don't have an electronic record and infrastructure. And those two moves are related to that. So they will no longer be an excuse next year. We're entering in an interesting part of the cycle, and that is we're getting better candidates who actually can make it into the top organizations. So we're seeing more better people. We're seeing better people. Allow myself to introduce myself. We are seeing better candidates interviewing for residency, but those candidates can also make it into University of Michigan, and Vanderbilt, at Yale, at Hopkins, and so forth. So we're in this cycle where we're not seeing so great candidates. Now we see great candidates, but we're losing a lot of them to the best places, and then we're going to start keeping them. It's a cycle. We've been there before. Okay? As you improve, that's what happens. We know where we're headed. More questions? Yes. Thank you. Huh? And they still will make it difficult for you. Andrew, tell me about the CCU, and then we go with Monica. Unless you want to go first because it's related. Great, great. Andrew, tell me about CCU and Jewish. There is no uncertainty there, Andrew. Okay. Do you realize that you're not only educating physicians to work there, that you're changing the way they do things? That there was no concerted CCU effort there until now. That there was no academic MICU there until a year or two ago. That the transplant program, the largest transplant program in this area, is there. That our residents and faculty are changing the way Kentucky One Health does things. It may be some of it the other way around, and that interaction makes us both better. It's not about uncertainty there. It's hard work, and it's not easy. It takes a lot of communication. We're making a big difference. How many are new faculty here today? Fred, I know you're there, Fred. Andrew, you're not new faculty. You are not new faculty either. Stand up, sir. Why don't you introduce yourself? Thank you. How about you, sir? Anybody else? Aha. Okay. Well, thank you, everybody. I hope you have a great day. There is no uncertainty. Teach that to those around you and enjoy. Oh, thank you. I need to turn this off. There you go. Yeah, yeah, yeah. Well, thank you. Thanks for coming. I got it. I like the what did you say in Spanish? Nuestro asunto. I like the nuestro asunto. cheerleading. I think it's true. I think it is true.
Kentucky won is really true. We get three states and stuff.
Yeah. Well, I mean, if you think about this curve, if you get that quote, if you get the center grant, if we get the Hampstead grant, if we get more money, we will be in that curve. I think this is a time to reinvest in this department. But who knows? If they had it.
They need to have some other departments also step up. We can't be the only
No,
one.
I agree. I agree.
Pediatrics is just,
I know.
you know, we're actually not the biggest clinic on Tri-State.
Well, in UOP, because many of their people are university staff. So actually, technically, we are, but as a whole, we're not.
No.
Yeah. Yeah, I've done they actually talked about the numbers. They have a lot of their secretary and staff are university people that work in the clinical arena. They didn't change the contract because it changed benefits and so forth. And by the way, number of faculty, we are higher. At least I asked them 2 months ago before I made this.
They have over 220 faculty. We're not even close.
Interesting. I've been told, and in fact, I brought this up to them, and they said that's true. I'll find out. It doesn't matter.
Yeah,
I mean,
I just when they present me their stuff on why 2